Hey, thank you very much. So I'm Ryan, Director of Research at Minicircle, and this is Walter, one of our CSO and one of our two founders. Um, I will pull up the slides here and share screen. So, today I'm going to talk a little bit about our plasmid system and the results of a decentralized human trial that we recently completed and wrote up. An overview of what I'm going to talk about today. I'm going to describe our plasmid gene therapy a little bit. I'm going to give a little bit of an overview of basic biology of follistatin, the target gene that we used for our first trial. And then I'll discuss the results of our recent trial and open it up for any questions. Our plasmid system, the main advantages of it are that it's cheaper and arguably safer than viral vectors. Our plasmid is inherently transient. It lasts, about 1 to 2 years naturally. It's non-integrating, and it's reversible via an oral antibiotic. Let me see if I can just go like, sorry, I'm just trying to get my screen kind of optimized here. So on the right here is just a cartoon illustrating the way we're using our plasmid system currently. So right now we're making use of secretory proteins. So follistatin is naturally secreted. By taking advantage of that, we can transfect a small number of fat cells around the abdomen and basically set up an export factory for our target gene. So that's a brief overview of our plasmid system. Brief overview of follistatin. So follistatin is a pretty well-researched gene. As discussed, it's secreted. It's known for improving body composition via inhibition of both myostatin and activin. In popular discussion, it's often described as a myostatin inhibitor. It's important to note in a scientific context that myostatin and activin inhibition are both important. It also has a very good safety track record in animal studies and human studies for, I think, muscular dystrophy. So on the right is a pretty famous image from a 2001 paper. You can see, I think it's basically a quadrupling of mouse muscle in follistatin-treated mice. It's important to note we neither see nor expect such dramatic muscle growth in humans. This is probably due to a dose issue and human biology itself. So we recently completed a decentralized, which is another way of saying international, human trial using our plasmid gene therapy. So we had 43 men and women, ages 23 through 88. Importantly, we saw no adverse effects related to therapy through 12 months of observation. And highlights of some of the results include about a twofold increase in serum follistatin, body composition improvements, and a reduction in extrinsic epigenetic age via a methylation clock. Trial logistics. So subjects were acquired, they volunteered and, spread through word of mouth. They had to complete a basic health screening. And the administration was carried out at the GARM clinic in Honduras. So first result that's noteworthy is serum follistatin increased over twofold, almost threefold. This was measured via ELISA, and follistatin actually kind of counterintuitively increases with age, but that increase is pretty clearly insufficient to counteract age-related frailty. For that reason, it's good that we saw an increase to a largely supraphysiological value, from just under 10 nanograms per milliliter to between 20 and 25 nanograms per milliliter on average. This is not completely supraphysiological. There are cases in which people have follistatin in this range, but most people's follistatin is not this high. And it's also important to note that despite raising follistatin to a level that's higher than most people normally experience, all evidence, all data we've generated are consistent with this being well tolerated. So I'd say probably our main result is that body composition improved. So fat-free mass measured by DEXA scan increased by about 2 pounds on average by 3 months. Some popular discussion about this result, people have said, oh, that's a very modest improvement. I'd stand up for this result because, you know, a lot of our trial participants were older. Participants were not selected for their physical activity. These are really normal people. And the increase in fat-free mass was really robust across groups, which I'll show in a second. We also saw up to a 10-pound maximum increase, which is a little more consistent with results that a lot of people would hope to get from a therapy like this. Additionally, body fat percentage decreased by about 0.8% on average. In terms of body fat, there are some case studies from this trial that stand out in my mind. For example, there was a 55-year-old woman who's physically active, but didn't really change her routine post-therapy. And she reached a lifetime low body fat percentage within a few months after the therapy. So that to me is a really good individual result. The improvements to body composition were consistent between both sexes and across all age groups, which again is really encouraging. Another good finding was that extrinsic epigenetic age decreased. So we partnered with True Diagnostic and looked at intrinsic and extrinsic epigenetic age measured via DNA methylation, estimated telomere length, and Dunedin pace rate of aging. So intrinsic, extrinsic, and telomere length all improved, but extrinsic epigenetic age was statistically significant. And the Dunedin pace did not change, and the improvements to epigenetic age were more pronounced in older age groups. Lessons from the trial include, in future trials, we should not just look at fat-free mass, which is really, I mean, it has some value on its own, but it's largely a proxy for functional strength. We definitely want to include strength testing in future trials. We should add more control groups, possibly a placebo group, and exercise. And we also need to have a longer window of observation. This is going to be particularly important for bone density. We saw a trend towards increased bone density, and we have at least one case study in an 80-year-old subject where there was rapid improvement to lumbar spine osteoporosis. But we think a longer window of observation might provide time to see average changes in bone density. And also we can take a closer look at the persistence of the serum follistatin increase and other metrics over time. Not pictured here, but I will mention it just for the sake of discussion. One safety concern that people have cited is, would follistatin decrease FSH, follicle stimulating hormone? When follistatin was first discovered, that was actually its biological function was, I think, suppressing FSH. The results are not pictured here, but we did not see a decrease in FSH, which is good. One other result to note is a minority of participants saw an increase in LDL, but the mean LDL value did not increase. So again, results consistent with this being a safe therapy. Some conclusions. Overall, our trial results are consistent with our plasmid providing a safe, effective, and less expensive gene therapy option compared to viral vectors. We're a small startup. This was a pretty scrappy trial, but we do feel like it produced decent results. And we learned a few lessons to improve trial design moving forward. We largely take a geroscience perspective. We're looking to, improve human health by targeting aging. So we have other target genes currently in development, including Klotho, which is also a secretory protein. The way we're kind of viewing this with cautious optimism right now is Follistatin may be body composition and frailty improvement, along with potential, cellular level rejuvenation as indicated by the extrinsic epigenetic age. And Klotho could be a cognitive function improvement, also plus potential rejuvenation. So those are our results, and I know that was pretty quick and pretty simple, but hopefully there were some things of value in there, and I'll open it up for any questions.